All right, guys. What anatomic site do you think this is from? Someone
Uh,
said something I can't hear. So you have these small hairs, sebaceous glands.
could it be the eyelid?
A little deep for eyelid.
Yeah, face as well. I mean, anywhere that has like a large abundance of like vellus hair and sebaceous glands.
Yeah, yeah. Okay. What else are we seeing?
The scattered cells in the dermis.
Okay, what kind of cells are there?
Melanocytic?
Mhm.
Or they don't look yeah, they look more jet black. Um,
I'm talking about these ones.
or like spindle, you mean? Or
Yeah, that's a spindly one.
So melanocytes.
They are melanocytes. What clued you into their melanocytic?
Like that sort of like spindly dendritic kind of.
Yeah, they're dendritic melanocytes. Okay, good. In fact, there's a decent number of these dendritic melanocytes. Here's another one. Here's another one. Some more here. Okay, so what broad category can we put this in?
see, this is well, this is pigmented. This is like melanocytic. You could say that it's neoplastic.
Okay, and is it in the dermis?
Yes,
Dermal.
dermal, a melanocytic infiltrate.
Okay, and it's more than normal, so we call that an osis. So
Oh, dermal melanocytosis with sclerosis
yeah.
is do not tell me. It's just dermal melanocytosis. And if it didn't have the sclerosis, then you'd have things like nevus avota or nevus avito.
Well, I mean that's the thing. Do you see any sclerotic collagen?
It doesn't look like it.
No. So what's our differential for dermal melanocytosis?
Dermal melanocytosis or congenital dermal melanocytosis or nevus avota or like nevus avito.
And nevus of
Oh, Sun's nevus or
sun's
Hori's
another
nevus?
one. Okay.
Hori's nevus.
Hori, yep. Nevus of Oda, Nevus of Ito, Nevus of Hori, Nevus of Sun. And when you said congenital dermal monocytosis, is that a new name for what I'm thinking of?
Is that Mongolian spot?
Yeah, yeah.
Don't get too triggered, Avi.
Oh, okay. I'm sorry for triggering you. I know we're not allowed to use that terminology anymore. Um, Mongolian spot is a forbidden term now, and we don't really use that term anymore, and you won't see it on the exam anymore. So wait, so what might you see instead of Mongolian spot? You might see just dermal melanocytosis, even though technically that's not really a specific term, that's a broad category.
Well, this
Um,
one's good. I think it's now termed congenital because it's at birth, but like yeah, congenital dermal
right,
melanocytosis.
exactly. So first they changed Mongolian spot to dermal melanocytosis, and then what happened was they realized that, wait a minute, that's actually not a diagnosis. That's just a category. That's not a specific diagnosis. In fact, you got less specific by changing it to dermal melanocytosis, and now I guess they're calling it congenital. What is it? Congenital dermal melanocytosis now, or congenital melanocytosis?
Yeah, congenital. I mean, I guess congenital dermal because like by nature of what Mongolian spot is
Gotcha.
in the dermis.
Okay, good. So you got your differential. This ended up being a nevus of Oda, for what it's worth. But yeah, you can sort of kind of rule some of them out. You know it's the face, so nevus of Oda will be on the differential. You're not going to say Mongolian spot. You're not going to start thinking it's on the scapula or something, or around the shoulder to the scapula. So good. That's good.
So this is a shave biopsy of a large.
How do
I mean,
you know this is a shave?
I mean, actually, that's a good question. You really don't know because it's cut off at the bottom.
Yeah,
It
Pretty
could have been,
large.
yeah, it could have
yeah,
been a very, very large bunch.
this is probably, yeah.
Or
Maybe
the
it's
top of
an excision.
an excision. Yeah. So unfortunately, these get excised a lot. Very like triggery. Very it triggers me, just like it triggers some people with the Mongolian spot. But a lot of these are getting excised. Some would argue more frequently than they should. So what do we? Let's start categorizing it. What do we think it is?
Yeah, melanocytic.
Okay, melanocytic.
So
It's symmetric.
Good. I agree. Symmetric. How's the circumscription?
it's good.
Good. All right.
It's like nests of melanocytes within the dermal papilla, kind of extending up
Okay.
with
What do you
some.
mean? What you mean extending up with? What do you mean? Elaborate on extending up.
I guess like kind of like up in like the DEJ.
Okay, there's that.
There's clefting there. I don't know, but the cells appear to be like raining down.
Okay, raining down. Yeah, some would describe this as like the bananas or whatever.
Mhm. Um,
Basically, but yeah, I mean, there's epithelioid and spindle melanocytes that they're fairly large in the epidermal component.
I'm looking for, oh, there's one, a little pink clump
This
of,
is what you were looking for right here.
yeah,
Camino body.
What's a
yeah.
Camino body?
It's like a bundle of type 4 collagen that stains positive for PAS.
Okay, and what are these cells?
These are like the melanocytes. Is that you were describing like single cell? Is it single cell discohesion or single cell dispersion? I thought single cell discohesion was a characteristic of melanoma.
Yeah, so there's some pagetoid spread here, right?
Uh-huh.
Stop.
But that's okay in the center of
Yeah,
space.
it's okay. You can have some pagetoid spread. It's all right. Don't pull the trigger on melanoma just because you see that. So let's take, okay, so more they're typically, yeah, so as you mentioned, they're typically more in the center. So let's evaluate that. I mean, you can see there's quite a bit. I mean, they're spitting, some of it is spitting out into the horn here. So let's take a look at the edge. Do we see a whole lot of pagetoid extension here?
Not as much.
Yeah.
There's,
And then when we get to the real edge, it's like not at all.
yeah.
Okay. So definitely more pronounced here. And then we'll go to the other edge just for good measure. As much or not as much?
Not as much.
Not as much. Good. Okay, so yeah, you can have some amount of pagetosis in this entity. And yes, as someone mentioned, it is typically more pronounced in the center than the edges. So what is it?
Spits.
Spits. Okay. Now, I'm actually curious now. So what did the attendings teach you guys about what to do with Spitz nevi when you make that diagnosis?
I
think
have not, yeah.
Actually, yeah, Nick, I haven't encountered one either, quite frankly, but my understanding is that I thought that these should be monitored for, well, actually, no, I think we see the majority of these times, like we would see these majority of time in pediatrics, and then is it like after the age of 6 months then or am I thinking maybe like congenital melanocytic nevus? I don't know. I never really see this. We never really get rid of
Okay.
them.
I feel like in my
I-
experience, it depends on the age of the patient, right? Like if there's a new like pigmented lesion in a 60-year-old and it comes back as a spitz, you would remove it, right? If it's in a 6-year-old, you would not remove it. But it also, I think some of it relies on like the Dermpath read, right? If it says just like pigmented spindle cell nevus of read and that's that, you might monitor it. But if they comment on like atypia or like a lot of the time the path read ends up guiding you.
Okay, good. I'm glad you provided that answer. There's a lot of, I'm going to give you all the different views and I'm going to tell you which view is the correct answer for your boards. Okay. So you're going to get one camp. I'm going to give you the whole spectrum because there's different views on how to do this. One camp is going to tell you that if you have a Spitz nevus, you make that diagnosis, then you re-excise it. And the reason you re-excise it is because dermatopathologists are just not good at identifying Spitz nevus versus melanoma, and it just doesn't matter. Just re-excise it. That's one camp. The other camp, another camp is a camp that says, well, if it's below the age of 10, if it's 10 or younger, or some arbitrary number, it could be 12 or 11 or something before puberty, then you monitor it, and if it's above, then you re-excise it. Another camp is going to say they're all benign, regardless of anything. And then another camp is going to say whether it's benign or not is going to depend on the features, the histologic features that are reminiscent of atypia or melanoma that will indicate such. So a completely benign looking Spitz nevus should be treated as such if it is diagnosed correctly. If you get something like that in a 60-year-old, you should be wary that it was not diagnosed correctly. But in the right demographic, even in teenagers, post-puberty, if it is a Spitz nevus without any features of melanoma, not beyond above and beyond what you would consider a banal Spitz nevus, you should not re-excise it, or you should not tell the patient they need to re-excise it. It is fine to monitor that. However, if there are features of melanoma, if there's extensive and too much to tolerate pagetoid spread and pagetoid cells and pagetoid pattern, if there are areas of single cell predominance of nest, if there's asymmetry, etc., then it would be much more reasonable to re-excise it. So, which view do you think is the correct view for your boards?
Probably the most like conservative one being like excising.
Incorrect. That is
Wow.
the wrong answer for your boards.
Work,
The wrong
okay.
answer is to reflexively excise it.
Wow, okay.
They're going to
Monitor
give it to you. I'm telling you, they will give this to you on your boards, and that's going to be an option. It's going to be a completely benign looking Spitz, and option one is going to be to re-excise it. And it's going to be on a child. Or someone that's like 12 or something, or 13 or whatever. The correct answer is going to be, so I'll just tell you right now, it'll be a benign looking Spitz. It's not going to look like a melanoma. It'll look just like this. And the correct answer is going to be to monitor. So for the purposes of your boards, the correct answer is going to be, unless you see something wrong, like an atypical spitzoid melanoma features or something like that, unless you see that there are features of melanoma here, if you see features of just Spitz and that's it, and unless they give you something crazy, like it's like a 70-year-old or something, in which case the right answer is probably going to be something like check to see if you got the right patient, call the dermatopathologist, or one of those answers. But otherwise, it's just going to be to monitor. And that might be different than from what some of the attendings teach you, and that's okay. I don't know what to tell you, but that for the purpose of the boards, that is the correct answer. Now in this case, you can say what type of biopsy it is, unlike the other one.
This
That's
is a
fine.
punch.
Okay. All right, cool.
A lot of pigment.
A lot of pigment.
This is looking somewhat similar, but yeah, there's a lot of pigment, some melanophages within the dermis. The nests here don't seem to just be confined to the dermapapilla, like it also like the really, so it's like a junctional component as well.
Would you say that this is bridging?
Well, what we look for in bridging, I mean, I guess you could make a case that in some of this news, but like before we get to bridging, because there are other features, like what's more before we even decide if we're looking for some kind of dysplastic or atypical nevus, nevus with architectural disorder, like what's going on with these melanocytes? Like describe them to me. Like this, you can argue is a bridge, but are they the typical epithelioid melanocytes we see?
No.
Okay, what's different? Well, if they're not fully epithelioid, then they might be something else with like
spindly.
like spindly. Yes, in fact, they're like oval-like. They're like oval to spindles in some areas. And they do have a lot of pigment, and you were reminded about that other case because this is in that family.
Pigmented spindle cell nevus of Reed.
Yeah, exactly. And you picked up on those features. You look at immediately, and like you're thinking along the right way. Immediately when you saw this, you picked up on the pigment. And you also picked up like, hey, well, this kind of looks Spitzy. This is like in the Spitz family, and you're right, it is. But unlike the previous example, we can just go back. Had some spindle hits, but unlike the previous example, this was a lot more plump epithelioid, and you can even see like it almost looks like it's pushing out the reedy. But as the name implies, this was more of that spindly component, and it has more pigment. It has these, this is good for, this is like the quintessential classic example of pigmented spindle cell nevus of Reed. So what are we going to do? Should we excise this?
No, you usually monitor, right?
Yeah. Yeah, good. Monitor. Totally fine to monitor. What about this one? Should we monitor this one?
Probably not. Looks bad.
Probably not.
Yeah, not looking good.
I agree. All right. What's looking bad about it?
It's extremely large.
Quite large.
It's ulcerated, looks like at the
Yeah.
top. It's extending to probably the margin.
Yeah.
I mean, I feel like the symmetry is not terrible, but it's just the size and the
Kind of hard to even evaluate it because the lesion also goes, this is also part of the lesion. It goes to a margin and beyond. And
Yeah, it goes to like the very far edge. There's even like loss. Like I even know like where the hell the dermis is. Like it's just like complete. Like all the infiltrate is like down below too, and down to a hair follicle. It's not looking great.
yeah. Okay, so let's try to figure out what this is then. So the first step, what's our steps general steps when we look at something we think is neoplastic?
What's like the cell population? I mean, we already kind of commented on the symmetry and the size, and
yeah. I mean, you want to look to see if it's in the epidermis, dermis, or both. Because sometimes you may find, I mean, you may just zoom in and be like, oh, what are these cells? Like, well, could this be a spindle cell squame? Could this be a melanoma? Could this be, if it was more atypical, you think could it be an AFX? But sometimes there's a little cheat code. There's an easy way out. Look for the in situ component.
So we're seeing like single cell, single melanocytes in epidermis, and then there's some epithelial spray.
So if there's a bunch of single cell melanocytes in the epidermis, and then there's just a bunch of tumor elsewhere that we may not know what it is, what do you think the lesion is?
Melanoma.
Yeah, you can see that here. Now you can even see the nests. So the in situ component is very helpful. It can take a lot of workup. It can save you a lot of workup. So, I mean, if you did have this differential otherwise, I mean, what kind of stains would you order?
Melanae, Sox.
Okay.
HMB, Sox 10, S100, Deepers.
HMB. Okay, so and if this was a spindle cell, let's just say hypothetically, it's not, but let's just say hypothetically this was a spindle cell melanoma, what would it stain?
Positive for S100, positive for Sox 10. It's desmoplastic melanoma that stains negative for HMB and for Melanae.
And yeah, and the spindle component and spindle cell for the dermal component. What about if this was desmoplastic or spindle cell melanoma, what would the epidermal component stain for? The in situ component.
Melanae, Soxen, S100.
What about HB45?
Positive.
Yeah. Yeah. So the point is that it's just when the melanocytes become spindly or desmoplastic-y, whatever we want to call it, they lose their some of their melanocytic markers, so they'll lose their melanae and they'll lose their HMB45. They'll retain their S100 and they'll retain their SOX count. Good. Oh, by the way, how do you measure this?
Oh, this is perfect. That's actually a really great question. It's like,
Well, you gotta go from the granular layer, which is
Where's the granular layer?
I have no idea.
I
Well,
think
what's
you
the
got
problem?
like, well, in this example, the top of the lesion is like supportive, like I don't know if that's like just also ulceration.
Ulcerated. Yeah. So the
Well,
problem is your granular layer is ulcerated away.
I would go at like the top of like I guess the spinous layer there.
The top of what you have.
Yeah.
Yeah, because you can't start here. How do you know this was the granular layer? How do you know this wasn't too far up? How do you know exactly? Maybe this was where the horn was. There's really no way to do that. You do the best you have. You go with the top of what you have to the largest degree. So, and then when I do my synoptics, I will actually make a note. I will say, because it is in two places. In one place, if there's ulceration, you'll say it's identified, and that also is important because ulceration makes a difference. It makes a difference to the staging. And the other thing is, I will also make a note if it potentially would affect the real measurement. I'll make a note by saying the measurement is at least, and then I'll put in parentheses due to ulceration, like granular ulcerated. So just so they know, like, okay, this, especially if it's at the borderline, I'll make a note like this is what I've measured, but it's at least, and the reason why it's at least. Whether that reason is because it extended to the base and it was transected, or because like what I'm supposed to start from was ulcerated away. All right. Where are we here?
This also looks like the face, a lot of hairs and sebaceous glands.
Yeah, face or scalp or somewhere around that area. Okay.
Pigment.
Yeah. Sun damage or no?
Yes.
Okay.
A lot of like subbasilar infiltrate.
Okay, there is an infiltrate. What is it infiltrating?
Looks like folliculitis.
Well, there is some areas where there's inflammation around hair that may be going down hair follicles. There's something else going down hair follicles too.
Melanocytes.
Yeah. Look at these melanocytes. And look at the melanocytes here. What are they doing?
pagetoid spread,
Pagetoid cells in pagetoid pattern, mostly nested or single cells?
single.
Okay. On sun damaged skin.
Yeah.
What do you want to do?
Already not good.
You could probably diagnose this, but you could do most days.
Okay.
Can
you make a diagnosis here?
This is like a lentigo maligna.
Yeah, good. That's what it is. You don't need the stains for this.
And a lentigo maligna is like specifically a melanoma on like solar elastosis.
So lentigo, and yeah, so lentigo maligna is a in situ melanoma on classically sun damaged skin, as opposed to superficial spreading melanoma, not the melanoma in situ on non-sun damaged skin. And then there's some people who regard, instead of lentigo maligna, they say lentigo maligna melanoma when there's a when it's more than in situ on sun damaged skin. So little more
Back on the face.
inflammation or less inflammation compared to the last one.
More
Yeah.
kind of like a lichenoid kind of pattern.
Yeah. No, it is lichenoid. I agree.
But like there are still, I mean, a lot of melanocytes, single cell melanocytes, pagetoid spread.
Yes. That's the key to pick up on, because it could be hard with a very dense lichenoid infiltrate to pick up on the melanocytes. But it's good. There are still melanocytes going down here. So what's all that lichenoid doing?
Attacking melanoma.
Yeah, what do we call that?
It's like a regressing melanoma.
Regression. Yeah, lichenoid regression of melanoma. Okay, is that a good thing or a bad thing?
Isn't it bad?
Why is it bad?
Because it's
Don't you think that it's good if your immune system recognizes the melanoma and can fight it off?
well, I mean, I guess in that sense it is, but the melanoma has to be bad enough for the immune system to recognize it as bad.
Good. Good. Meaning specifically what might have happened. It raises our pretest probability that something might have happened here.
Like metastasis?
It might have, to where?
A lymph node?
It might have gone to a lymph node, and that
makes
may have
sense.
activated the immune system. So some people say when melanoma goes to a lymph node, one of the things you are more likely to see is certain regression features of the melanoma. And the idea is that because it has gone to a lymph node already, the immune system is more attuned to the melanoma, and that's why you are more likely to see some of the regression features. So you might think it's a good thing that it's recognizing, but it's a bad thing, because in many cases the reason that's happening in the first place is because, well, it was aggressive enough for the immune system to be activated, just as you said. Good.
So is that last one, Avi, just another melanoma, but we would have considered it more aggressive, or
Well, this one is a melanoma that has regression.
melanoma with regression? Okay.
So the slide here is not the best quality, but let's take, for the sake of the argument, let's just say there's no cellular elastosis here. Because I know there's some stuff that you might look at and be like, oh, this is cellular elastosis.
So we're dealing with either an in situ or a superficial spreading melanoma.
Well, wait, what is a superficial spreading melanoma?
So it's a full-on melanoma.
Yeah, so
yeah.
what's the difference? So you say, so melanoma in situ, yes. Melanoma in situ, and if there's no cellular elastosis, you can call this okay, superficial spreading melanoma subtype. So that's all that the point of that was. What about this one?
with another lymphocytic infiltrate that's subbasilar as well. It's
Is
pretty
it
crowded.
lymphocytic?
Uh,
They're a little too pink, I would say. So
yeah, it does look pink.
jet black. So these are also melanocytes. But they're, well nested. They're not really single cell, just not any pagetoid spread. Um, I don't know. I mean, we see them in a couple nests in the video, it looks like. So it's like a compound nevus.
Yeah. Now, in this compound nevus, this it kind of looks like. Is there anything off about this? And it doesn't have to be a malignant off. So it might not be the easiest to see over here, but like if we see the lesion over here, the nests are kind. I mean, this is kind of what normal looks like. There's a junctional component, and the dermal component is right next to the junctional component. But
I saying that like in the other part, like there's like a kind of a wide space
it's almost
between.
like a Gren zone here.
Yeah.
Like, why'd that happen?
Were these just coincidentally to like a junctional and then like a blue nevus that are next to
You
each
see how
other?
the collagen here is a little bit more fibrotic, and it's hard to see because, like, in some cases the scar is obvious. In this case, it might not be as obvious because there's a reedy pattern here. So it might be pretty old, and it might have been a very superficial sample.
Was like traumatized before, or
Yeah, the idea is that someone basically did this in the past. They did a very superficial shave.
Oh, it's just like a recurrent nevus.
Yeah. So it's just something that happened to have been sampled before. That's all. And it's not easy to spot that. But if you want, by the way, here's a question they can ask you. If you want to know about recurrence, recurrent nevus, if you want to have an idea of whether there was a previous done or whether it was atypical. So recurrent nevus can look a lot more atypical than this. And you might be wondering, like, okay, well, is this a recurrent nevus or is it a melanoma? So what's the best way to do that? If you were at the scope,
Are
Shoot.
you
what are some things you could do? Let's start there.
gonna look for like signs that it was like scarred?
Okay, so I mean, well, recurrent nevus versus recurrent melanoma, both will have a scar, right? So the presence of a scar might not help you because they're both going to be there. So one thing you can look for is if the atypia extends beyond the scar, or is it confined to the location of the scar? If it extends beyond the scar, more likely melanoma. If it's confined to the location of the scar, more likely recurrent nevus. But is that the best thing to do to rely on?
And then I guess no.
No. What's a better thing to do? And it's not that complicated.
Look for the
Better
passport.
print.
Look for the previous biopsy. Yeah. Look at the previous. What did the previous thing show? Pull the slides. Or get the report at least. If it says nevus, it's probably a nevus. If the previous one says melanoma, it might be a recurrent melanoma. And you'd be like, wow, that's so obvious. Why did it? But yeah, that's actually a question. Anyway. What do we think about this one?
So again, we have melanocytes in the dermis, maybe some nests in the tips of the really. Looks fairly well circumscribed.
Mm-hmm.
It was pretty big, but I guess Nevi can be big. I don't see any pagetoid spread.
All right, so we're good on benign nevus. What kind of benign nevus is it?
Um, oh, it's congenital.
Good.
It's tracking down like the nexa.
Nexal structures. In some areas, you can see it's almost like in a perivascular pattern and tracking down the nexal structures. Okay, good. You got that. Excellent. All right. What's the size on this?
Someone took a chunk out of them.
Yeah, it's a big chunk someone took out of someone. Anything you're noticing on low power?
It's asymmetric, although it could have just been sampled asymmetrically because it seems like most of it's
Now,
sort
look
of at the bottom.
this. See that? What's different?
Yeah, it's like bluer.
Bluer. Why might it be bluer?
Could be different types of cells, could be that the nuclei are more like the NC ratio is
Yeah.
higher.
Higher NC ratio. Okay. Well, let's look at the less blue part first.
Okay, so we have melanocytes, it's like there's a lot of them, but again, kind of looks more benign in this area, tracking down the next
Mm-hmm.
this looks more just like congenital, like what we saw before.
Yeah. And it's a very large, if it's congenital, is it a small congenital nevus or is it like one of those giant congenital nevus you might see?
That's huge.
It's a giant congenital nevus. What are we worried about in giant congenital nevi?
Melanoma. I think like 1 to 2% of congenital nevi carry that risk.
Of a transformation risk. Is it 5% or is it 1 to 2%? I forget on what the updated percentages are.
I thought it was 1 to 2%, but someone correct me if I'm wrong.
That I think is right.
Okay. Go with that.
Yeah, it's a tiny percentage.
1 to 2 sounds right. Okay. So what do we think about this portion?
Probably an area transformation to melanoma.
Yeah. What makes you think this is the area of it's transformed?
We see features of melanoma, so like
Yeah, the horn is gone. There's a single cell melanocytes again.
Yeah. So this is the transformed area. Fortunately, it happened in this case. All right. What about this one?
I'm just gonna go off on a guess with the scanning. Is it blue nevus?
Okay. This is it. What makes you saying blue?
Because you have that like ball, like nodule
That big blue thing that's in the middle.
Oh, come on. There's lots of blue things in dermatopathology, and there's lots of blue things that might be in the middle. But you're right. I'm not saying you're wrong.
I mean, I at this like scanning sort of power I can't say for certain it goes in melanocytes.
Yeah. I mean, well, let's take a look at some of the things we're noticing on low power. So, number one, look at this collagen over here. Look at this collagen. Is there any difference?
Yeah.
More dense and sclerotic.
Yeah. So some blue nevi can have their own sclerotic collagen. That's one. And yes, you notice, I mean, obviously there's pigment here. There's melanin pigment, and there's all sorts of cells here. So you're thinking blue nevus, but can we be more specific than that?
Oh, like compound or deep penetrating or cellular. You mean?
Yeah, that's what I'm getting at.
I think it's common blue nevus, right?
What makes you think it's common? What do
So
you
you
see in
have
common blue nevus?
so you have sclerotic fibrotic stroma.
Okay.
Uh,
And what else do you have sclerotic stroma in? Is it only common blue?
I'm not sure. I think epithelioid doesn't have sclerotic stroma, but I'm not sure about cellular blue nevus though.
All right. What type of cells do you see in common blue nevus?
Uh, melanocytes.
What kind of melanocytes?
Spindled?
Yes, and what kind of spindles? More specifically,
Dendritic?
dendritic melanocytes. In this case, there are some dendritic melanocytes, but there's also another population here. Are these dendritic melanocytes?
Is it epithelioid? No.
Well, what are we'll get to epithelioid blue, but what are these cells?
The histiocyte?
Yeah, spindled, exactly. They're like oval to spindled. And sometimes you could even see like this, in the alveolar type of what this is, you can see like in some cases they've described like sharp demarcation between this population and of these spindled melanocytes and then the dendritic melanocytes and melanophages with the sclerotic collagen. And in some more infantilizing versions of dermatopathology, you might see an allusion to the shape. If I were to complete this on the other end symmetrically, this might look like a
Dumbbell. Deep penetrating.
dumbbell. Yeah. Does that remind you of anything?
I thought it was deep penetrating that's dumbbell, but I also could be confusing it with cellular. I can't remember.
So which one is it, guys? Is it deep penetrating or is he confused?
I thought it was cellular, but I'm not sure.
Yeah. So cellular, this is cellular blue. So it's not just common blue that have their own sclerotic stroma. Cellular blues also have their own sclerotic stroma. So don't just say that you can know the subtype just by the sclerotic stroma. And in cellular blue, some people who have tried to make this easy have said, okay, well, look for some dumbbell-like pushing border projections. It's not a terrible thing to look for. And yeah, it is this one in this example is dumbbell shaped and it has that bulbous pushing border. And then it does have these populations of more spindled cells. And just like other blue nevi, you'll see dendritic melanocytes and then all the melanophages in the sclerotic stroma. Compare that to this.
Interesting. I would not have thought that this would be like a blue nevus just based off of a cursory glance. It doesn't look like one.
Yeah, doesn't look like much. But let's just get the category right. So do we agree that this is melanocytic?
Yeah.
Okay. Do we think it's malignant?
No.
No. Okay, I agree. Do we agree that it's also going deep?
Yeah.
Is it a dumbbell?
No.
No. Doesn't have that pushing border. It's more of a wedge-shaped infiltrating pattern, if anything. Anything else we notice?
The stroma is like kind of gone. It's hard to say definitively not whether that would be considered sclerotic.
Yeah, it's not really as sclerotic. I mean, you could argue like this area might be, but then also if you look, there are some sclerotic areas of just the collagen itself in the normal collagen where the lesion isn't. So if it is increased more sclerotic collagen, it would be mildly increased. It wouldn't be anything crazy, which is okay. But there's definitely a different type of cell here. I mean, that's not, I mean, first of all, like, is it spindled melanocytes like we saw in the last one?
No, it looks like epithelioid.
Yeah, this is epithelioid, and it's kind of plump epithelioid. In some of these cells, they have more of a plump, almost like sort of grayer type of
Fusiform.
cytoplasm. And some people say there's a little bit of spitziness up top. Some say that this entity can have a little bit of spitzoid features up top, unlike, and that's more common to see in this area than the cellular blue nevus. So this, oh, actually here, see, this is even a better example. See, more wedge shaped than dumbbell shaped. If that helps anyone. But again, you're not seeing that spindled archetype that you saw in the last example.
So is this deep penetrating?
Yeah, this is deep penetrating. And this one is?
Would we have to really know for the purposes of the exam, like differentiating between things like deep and epithelioid and cellular?
Yes. For the
Okay.
Dermpath core, yes.
Okay.
So now that you are required to know that, which one is this? Well, first of all, what I mean, there's one good thing about it is they like certain things that are easier. Sometimes they give you giveaways that are like supposed to be giveaways that might not be in real life, like this dumbbell shape.
Oh, the cellular?
Cellular, good. What about this one? What's different about this one?
It's really, really pigmented.
Really big, yeah. So I mean, the first thing I usually notice about these things is it's a bit more pigmented than I usually see. And in fact, for those, when I was earlier in my training, and for those who are earlier in their training, it might seem, one thing I noticed that it might seem is that you really almost have to peer through the pigment just to see the melanocytes. So the overall border, I mean, we can agree that this is, well circumscribed. We can agree that it's symmetrical, it's large, and it's pushing, but it's not infiltrating. And then a lot of pigment, but then there are cells here. So let's describe these cells. Small or large?
Smaller.
Epithelioid or spindle?
Spindle.
Spindle.
See, like I know this is an epithelioid blue nevus, but I still would have also said the cells were spindled. I think it's because they're like in between the collagen bundles, and there is so much pigment you can't see the cells.
Look at where, I mean, so there are some dendritic melanocytes. That's fine. But I'm talking about the cells that you can see. So, all right, let's talk about the different populations. So, forget about the dendritic melanocytes, which are technically spindled. I agree on that. But like, look at this cell. We said we're talking about these small cells. Do these look like spindle cells to you?
No, those are more round.
Okay. So small epithelioid cells. Nested or in single cells?
Single cells.
Yeah, gotta reload this. So there's four. I mean, usually from what I've seen, that's the predominant cell other than the dendritic melanocytes that I've seen. There's been four cell types that have been described in this entity. So there's been small epithelioid melanocytes. Then and these are either in small nests or in single cells. And then there's the large epithelioid melanocytes, and sometimes they can be binucleate and have almost like a Reed-Sternberg cell appearance when you see them. There's the dendritic melanocytes, and then there's the melanophages. And if you think about what this entity used to be named, which is what?
Animal type?
Which animal specifically?
Horses.
Horses and equine melanoma. So the 4 cells, you could think of the 4 horsemen of the apocalypse, if that helps you. But really, I mean, the thing is, like, you should be able to recognize this. Like, your antenna should go up by the low power features. Very, very pigmented, well symmetrical, well circumscribed, a pushing type of border almost. It looks benign, well circumscribed, but it's not really infiltrating. And then you can see not just the dendritic melanocytes, but also these small epithelioid melanocytes. That's a very good thing. For what is this called now, by the way? You mentioned epithelioid blue. There's another name you need to know for that.
Like the nevocellular nevus?
Is this a melanoma, dendritic melanoma, or
What's another name for epithelioid blue? Another name for equine melanoma, animal type melanoma that's no longer used. Starts with the first thing it starts with the first thing you see when you see the lesion. What's the first thing you saw?
Melanin.
You saw the pigment. Yes, you saw the pigment.
Pigmented blue nevus?
Pigmented. And then you mentioned that this was an epithelioid blue. So guess what the second word is?
Epithelioid.
Epithelioid. Pigmented epithelioid melanocytoma, or PEM. So pigmented epithelioid melanocytoma. And that's, from my recollection, when this entity is asked, that's the name they use. I haven't seen epithelioid blue used. I've seen pigmented epithelioid melanocytoma used. But like everything in the boards, just like you need to know that Haley is also called benign familial pemphigus for whatever reason. And yes, they can give you a question like that and say, oh, benign familial pemphigus, and you may not know what that is, and it would be very unfortunate if you got everything else right and you got to Haley, but you didn't know the other name was benign familial pemphigus. You will get the question wrong.
Avi, and just to clarify, you're not saying animal type melanoma is this entity, right?
No, I'm saying that was an older name.
Well, so animal type melanoma referred to a subset of melanomas that were extremely pigmented, heavily pigmented, but they were melanomas, like, they were obvious melanomas. All right. So, and then pigmented epithelioid melanocytoma, yeah, that's a term that came about for large blue nevi that had epithelioid morphology, some of which ended up in people's lymph nodes, and the patients did just fine. And then, then there are rare cases that people describe where the patients did so well, and so they came up with this terminology, which hasn't stuck really well, right? And then, then there's the epithelioid.
Here's
blue.
what pathology outline says, at least. Epithelioid blue nevus, animal type melanoma, not recommended based on WHO, benign melanocytoma. I don't know if maybe some people call them the same thing.
Yeah, they're definitely not. So, yeah, animal type melanomas, it's kind of the term Clark used to describe, heavily pigmented melanomas. So that's a little misleading, that pathology outlines.
Gotcha. Yeah.
Yeah, it is misleading. I know Lebois' textbook classifies it the same way as you just said, Shane.
Yeah, interesting. Because I think I heard something from I'm not. I have to think who else is saying this then. But okay, that's good to know then. But in any case, we don't use that term anymore, thankfully. What about this one, guys?
Well, so kind of keeping along with theme, this looks like a blue nevus of some sort.
Okay, and again, what makes you say blue nevus?
Well, we see a lot of melanin pigments. It's like that big ball of cells in the dermis. I guess those look like melanocytes on willpower.
Okay, what kind of melanocytes?
They look a little spindly.
Spindled. Spindled melanocytes. And in this case, they weren't nice enough to give you the specific cut that gave you the dumbbell, right? So it can't be cellular blue nevus then, right?
Well, I guess it can be if we're looking at the bottom of the dumbbells here.
Yeah, of course. Yeah.
But kind of
So
like
go by,
square.
so we go by the features, right? Don't go by the dumbbell. That's the only reason I put this in. All right, good. What about this one?
So kind of looks like a not congenital, well, maybe congenital nevus, some sort of nevus.
Good, some sort of nevus. What makes you say some sort of nevus?
As opposed, doesn't have any like concerning signs of malignancy. There was a melanocytes, but then there's some probably lymphocytes peppered in between the melanocytes.
Mhm.
There's a jet
So
blue,
what kind of nevus do you think it is then?
one that the immune system is not happy with.
I'm sorry.
The immune system is attacking it.
Is it attacking it? So this is I mean, well, in a sense, but
Right. So this is the difference between like mingling and riot police or whatever. There's like a halo nevus.
good, good. So the nevus is benign. There's no features of melanoma here is the key. And then you pick up on the lymphocytes. Now most people, I'm glad this is the order, by the way, because when I'm introducing most people to this, the first thing they pick up is on the melanocyte. I mean, sorry, the lymphocytes, and they completely don't even notice the melanocytes. And they're like, oh, well, this is some kind of inflammation, it's some kind of like, and then it's like, oh shoot, there's melanocytes in here. So I'm glad you picked up on the melanocytes first, because that makes the process a whole lot easier. So yes, you're correct. Halonevus.
What's the, oh, they use like cocktail party as the reference for that? For Halo Nevis?
As opposed to the riot police.
Correct, yeah.
If that helps you,
I don't even know, I mean, I really don't even know what that means. Like the whole cocktail party, like what kind of cocktail party? What the
I don't know what kind of cocktail parties you guys are going to. Listen,
Me neither. Like I don't know what that is.
So this looks like just like a solo leg to go.
that's all it is. That's all it is. Good.
Yeah.
All right. Is there pigment over here?
No.
Is there pigment over here?
Yeah,
And here?
yeah.
And here?
No.
Okay. Is the pigment very easy to see? Like really easy to see, even on very low power?
Yeah.
What do you think it is?
Was it just like a like just a regular lentigo, not solar lentigo?
Well, it is a lentigo and it's not a solar lentigo.
Lentigo simplex?
So there's one type of lentigo that is both even clinically, but even clinically it looks very intense, and on path it looks very intense. Because remember, you were able to see it like this. Not every lentigo you're able to see like this. In fact, most you kind of have to go in a little bit. It's like someone took some ink out of their pen.
Oh, ink spot.
Yeah,
Lentigo.
there you go. Ink spot lentigo. Good. Where are we over here?
Volerskin?
Why do you say volar?
Oh, well, I thought I saw like a stratum lucidum.
It's like, is it weirdly stained? Why is it so intense?
Yeah,
So different labs have different staining protocols.
I think this is like mucosa.
Yeah, it is.
There's like no really, I mean, kind of looks like there's a tiny stratum corneum,
Or
but then,
junction, mucosa or junction of mucosa.
and then, I mean, there is a granular layer. I don't know, it's so hard to tell because of how dark the epidermis is staining.
But you can see a couple of things, right? So one is look at the bulbosity of the reedy.
very bulbous.
Yeah, and that's something you could see on mucosal surfaces. The other things you can see, like we're missing certain things, right? We're missing hair follicles. We don't have hair follicles growing out of mucosa. There's a nexus
Labyrinth.
that are missing. There's also in some areas when we especially get close to mucosa, there's a granular layer missing. But this in some areas we have it if it's more at the junction, or if it's more we got some cutaneous in. So it's probably at the mucocutaneous junction somewhere. Okay. So why might we be biopsying mucosa? What are some of the things we could look for?
Oh, for mucosa, I mean, you could have melanotic macule on the lip. You could have that's, or like presuming that's pigmented, right? So yeah, melanocytic macule, or you could have like Peutz-Jeghers or something like that, where like there's like hyperpigmented macules around the lips as well.
You
Okay.
can't
Anything else we get in the mucosa?
you can get melanoma on the
Okay, melanoma, even melanoma you can get.
Amalgam tattoo.
Amalgam tattoo, that's another one they like asking. In this case, let's not presume about pigment. Compare this area of basal area, something like this. Is there pigment?
yes.
Yes.
Are there melanocytes? Is there like a melanocytic neoplasm, or is there just
Pigment.
increased pigmentation?
It just looks like there's increased pigment.
Yeah, so what do you call it?
Amalgam tattoo.
I think it's
Amalgam tattoo.
melanocytic
Wait a minute.
Not melanin thing. Lentigo.
Oh yeah.
A lentigo. Yeah. What
Yeah.
would we see in amalgam tattoo? Like what is, by the way, what is an amalgam tattoo?
It's like from the actual like from like a dental procedure, from a dental filling, and then there's mercury in it, I believe, and that's the thing that like ends up pigmenting the mucosa.
Yeah, some people say there's also silver in there, and you're kind of like doing a silver stain, and what you're seeing is that it basically does a silver stain on the elastin fibers. It's like an in vivo silver stain amalgam tattoo. But yeah, that you wouldn't just see just melanin pigment in the basal layer. Like that, I don't think there's much of anything else that does just that other than a lentigo.
have a question about
what's
this between this and a melanotic acanthoma.
Mhm.
So, um,
Well, you mean melanoacanthoma?
yeah,
Okay.
this looks like acanthotic, and also with the pigments. So
Well, melanoacanthoma, it is also, well, first of all, couple things. Number one, anatomic site, right? What's acanthotic for one side might not be acanthotic for another side. So this actually isn't that bad. Or not that acanthotic. This is actually, like, you can see a lot of biopsies of normal mucosa that'll look like this. But number two, melanoacanthomas have dendritic melanocytes in them. And do you see any in here for
No.
melanoacanthoma?
So I should expect more like dramatic acanthosis.
Well, it's all context dependent, right? So if you're on an area that isn't normally acanthotic, then then okay, this might be acanthotic. But some areas are just naturally have more acanthosis, and that's just not acanthotic for that site. So look, just like if you were to get a biopsy from the palms or soles, you'd be like, oh wow, there's a lot of thickness here. Does that mean it's acanthotic? Like,
No.
not necessarily. It could just be the palm, because that's how a palm is, or that's how the sole of your foot is. It's the same thing here. Like, reedy are bulbous and acanthotic, but that's normal for mucosa. So your threshold has to be higher for that. All right, what about this one?
So there are a lot of melanocytes in the papillary dermis, also deeper dermis. So and they're all kind of lining along the radial edges somewhere. I mean, not everywhere, I guess.
It seems to be pagetoid spread and like splitting themselves in the stratoconium.
Okay. Yeah, and it's asymmetric, large. What are you thinking it is?
Melanoma.
Okay, good. Now, in this case, it should be a little more clear.
So one thing that's kind of I'm seeing that's striking is the fibers in the dermis look like scarred.
Yeah, good. Good. Because what's going on in this area?
Probably biopsy.
Yeah, what makes you think that? Okay, so describe it.
Well, so I mean, it's just like something that looks pigmented, and then you have the scarring because of like the east to
What's
west,
telling you there's a scar there?
the east to west kind of collagen orientation,
Okay, good. And what about,
maybe like a north to south vessel.
yes, north to south vessels. So, and then what do you have in the scar?
Melanoma.
Well, is it a melanoma or is it a recurrent nevus?
I mean, doesn't look great.
Because remember, yeah, it doesn't look great. Do recurrent nevi look great?
Not usually.
Usually they don't either, and could be very hard to tell sometimes. So what can we do?
Look at the EMR for the.
Look at the prior biopsy. Yes, number one, look at the prior biopsy. Um, other things you could do is like, okay, well, let's take a look at where the scar ends. It's still going. It's still going. Here it's gone. And do we see melanoma?
No.
No. So what was this called? It was called a recurrent nevus. Compared to this, so scar or no scar?
Scar.
Scar. Good. Atypical melanocytic proliferation?
Yes.
Yeah. All right. Clearly some in situ atypical proliferation. Let's check all our cuts. And unfortunately, the scar we can't really evaluate how much it extends because the scar kind of goes to both edges. So in this case, I'm just showing this to give you an example, but you do see a whole lot, unlike the other one, there's a whole lot of areas that are very just a run of single cells, but it could be hard to differentiate. Like the other area had some single cells, quite a bit of single cells as well. So your strongest bet, and this one ended up being the recurrent melanoma, but the strongest bet really here is get the prior. Okay, so is this acanthotic?
I don't think so.
Why? Look at how big this like stratum corneum is.
Volar scan.
It might be
Or-
volar skin, right? Context. And by the way, what are these things?
Or Meissner corpuscles.
Yeah,
Mhm.
Meissner corpuscles. Where do we have those?
On the hands.
Hands, fingers, yeah.
Okay, there seems to be a lot of melanocytes.
There are a lot of melanocytes.
Well,
Tell me more about these melanocytes.
Um, seems to be like, I don't know, like all confined to the basal layer, but there's this more single cells and then yeah, not really seeing nests.
Are they traveling up the arches of the
Yeah,
yeah. So in acral melanoma, one of the things are like melanoma is your arch nemesis. Like one thing that can fool you is when they start traveling up the arches in single cells. That's a very concerning thing. And even in here, actually, you start getting pagetoid cells and pagetoid pattern.
there's the acral lentiginous melanoma.
Melanoma.
Yeah, and if you compare that to this, and this is the point. So, first of all, is this acanthotic?
This is also in volar skin or
Yeah.
acral skin. So again, context, but unlike the last one where you have like these single cells going up the arches, this looks like more it's nested. You don't see those single cell population as well. It doesn't look so atypical.
Mhm.
So acrolentigenous nevus.
Good. That's good. Now, is it completely typical, or are there like some cells that are in single cell pattern?
Yeah, there's some that are in single cell, but I think it's always just gonna look by nature of the fact that it's acral gonna look a little weird.
Yes, good. That's exactly what I wanted you to say. Exactly. So the rules are not exactly, the threshold is not exactly the same for equal nevi. They can, and there's different theories for why that is. Some people say it's just like similar to like a special site nevus, because like if you think about it, if you have this on the bottom of your foot, what's happening to it every day? You're stomping on it. It's like you're stomping on your nevus every day. And so like, okay, well, it's not that surprising that it looks a little atypical. By the way, what are the special site nevi? What sites are those?
Acral is one.
Besides acral, what are the
No, probably I'm guessing anogenital.
Okay. Yes. Is there an easy way to remember this? So
Probably.
yeah. So one way to remember it is the Elston way is anywhere you can get a piercing is a special site nevus. That's so include all of those, and then all the places you touch when you do the Macarena dance. Those are all also special site nevi. So where do we get where can people get a piercing?
Ear, nose. Gosh.
Brows. Come on, let's not be too conservative here.
A lip.
Nipple.
Nipples, and with that, the nevi on the breast can be special site nevi. Okay. Where
Belly
else?
button.
Belly button. Yep, that's another special site nevus. And some people say the belly button is the area because there's different theories about that. Some people say the belt rubs against the belly button area, the navel area, and so that's why it's a special site nevus. I don't know if anyone really knows, but okay, where else?
Anogenital.
Anogenital. Yep. You can get piercings there. You get special site nevi there. And then all the areas that you can actually do the special when you do the Macarena dance. Anyway, if that makes it easier to remember, you can do it that way. Oh, also the one other thing is the areas that get get shaved a lot. So if you razor your face often as a guy, or if you razor your legs often, which is commonly seen in the legs of women, some people consider that special site nevi. You guys know what this is. I don't have to belabor the point.
The nail melanoma.
This is down. Yeah. Okay. I don't have to belabor the point. This is
Acral melanoma, acral lentiginous melanoma.
all right. Good. What's the sun damage or no sun damage?
Yes, the sun damage.
Yes to sun damage. But what happened here?
It like went away.
It went away. The sun damage is gone. So they got like a resurfacing Fraxel or something, right? They got or CO2, or they got a Croton oil peel that these new people are doing, and they got a beautiful new face, right?
Really? I'm gonna say no.
No,
They
no,
didn't get a Kutan appeal.
that's not what
yeah.
happened.
Like the desmoplastic change.
Okay, so that's a hint. So there's a hint for desmo. What other things are we going to look for desmoplastic melanoma? What about what's going on here? What's this?
Lymphs.
Yeah, conspicuous aggregates of lymphocytes. That's one thing you can see. What else? So we talked about the desmoplasia, conspicuous aggregates of lymphocytes. When there's a neoplasm, what's such an you don't always have it, but if you have it, it's great. What's the life hack? Helpful to have a life hack. They work sometimes, especially when they work.
Thing like Padres.
The in situ component, right? Because remember, you don't know what this is. These are spindle cells. They could be. There's a whole differential for this. But if you see the in situ component, sometimes that can give it away. If you see pagetoid cells and pagetoid pattern. Now, you don't always see that, by the way. What percentage, does anyone know the percentage of desmoplastic melanomas that don't have an in situ component? And even here, it's not that obvious, but there are some people might just even call this melanocytic hyperplasia. But there's some here. So in about a third of cases of desmoplastic melanomas, there actually isn't an in situ component present. It's scary because you can some cases are much more subtle than this and they can be missed. But those are your clues. So you have a spindle cell proliferation, you have a desmoplastic area, and you have these conspicuous aggregates of lymphocytes. And those are your low power clues to be like, okay, wait a minute, something's going on here. And I need to be careful about it because you don't want to miss a melanoma, even though desmoplastic melanomas aren't as aggressive. Still. But here, I mean, and you do see, by the way, melanin pigment here. Don't have to. So again, how is it going to stain?
S100 positive, SOX10 positive, HMB negative, and Melan negative, except at the in situ component where they
Perfect.
stain positive for all four.
Perfect. Exactly. Good. What about this?
I feel like this kind of just reminds me of what we saw at the beginning, the just increased melanocytes in the dermis, like the dermomelanocytosis, but there's probably more to it.
Well, are the melanocytes dendritic?
No.
In fact, there's even a little bit of, in some areas, very oddly, more in the center, There's a little bit of pagetoid spread and pagetoid pattern.
There's a spitz nevus.
Can't really rely on that. It's very subtle in this case, but yeah, this is a type of spitz. Is there desmoplasia here?
Yes.
What kind of spitz nevus might that be?
It's a desmoplastic spitz nevus.
Yeah. And I kind of have a hard time describing how to recognize these. I mean, it's one of those things for me that I kind of just recognize the look of the melanocytes in dermal spitz nevi and desmoplastic spitz nevi, and then I just get it. I don't know if anyone has an easier way of like describing any clear giveaways for desmoplastic spitz.
Well, by definition, spitz nevi have big nuclei, whether they be epithelioid or spindle. So you're probably picking up on the fact that the melanocytes are just large and uniform. And then, yeah, the stroma is similar to what you might see in a desmoplastic melanoma. But the melanocytes, like you are noticing, are very different. And then just to clarify a point, Javi, with the desmoplastic melanoma, so there's kind of classic desmoplastic melanomas that the cells they're almost dendritic, right? And then a subset of desmoplastic melanomas can have a spindle cell component. Those spindle cells are more plump. So melanomas, they can be purely desmoplastic, or oftentimes we'll see overlap with desmoplastic ones that have dendritic melanocytes and then the more spindled ones. Those more spindled ones will pick up like melanate.
Oh yeah, those ones I
right?
imagine it'll be easier to pick up, but the ones
Right,
that are dendritic are
right. The dendritic ones are the ones that are just blank for the melanate and HMB45. So there's a kind of a little subtle distinction there.
Gotcha. Okay, that's good to know. And yeah, the dendritic ones, yeah, I mean that all makes sense. Of course, the dendritic ones are going to be like, okay, well, I missed that one. So those are the danger ones. Okay, up top, what do we see here?
Melanocytes.
Okay.
Look well nested.
Yep, well nested. And what happened here?
Yeah, ballooning of the cells.
Ballooning. Okay, so what do we call that?
Balloon cell nevus.
Balloon cell nevus. Do we have more ballooning?
I don't know, these cells don't look that great.
They look different, right? These balloons, something's wrong with these balloons.
Yeah, they look very atypical. The nuclear pleomorphism, X-rays, probably some have multiple nuclei, so it's like a
What's an easy way? Now, this can be a lot, like, who knows? Who knows what this is? I mean, this could, like, but what's an easy way we can tell what it is? An easy way we can tell what it is. Like, maybe this is, I don't know, some kind of like weird malignant like a foamy histiocytoma, or maybe some kind of liposarcoma, even though they don't really look like that. But what's an easy way we can really nail this lesion down?
try to look for an in situ
Look
component.
for the in situ component. I keep drilling that in. Yeah. So what's the in situ component telling you?
The melanocytic,
Melanocytic. Okay, so what is this?
like balloon cell
A
melanoma.
balloon cell melanoma. More of the same. Okay. And this?
This is a neural nevus.
Neural. Does this look like a neural nevus?
These aren't
Neurotized nevus? What does it look like? What colors are they? It's not a trick question.
pink and blue.
Pink and blue, yes. Pink and blue. It's taking up both the hematoxin and the eosin. What do we call that? These two-toned, not two-ton, but two-toned. Call them amphophilic. These amphophilic staining cells. And they each look like, sometimes in here, like they look at that they're sitting almost like in their own lacuna. You may not always get it, but again, sometimes you do. So what can we check?
Like an in situ component.
And is there anything?
They're like, yeah, weird looking melanocytes.
Okay, weird looking. Yes, they're weird looking melanocytes. But what kind of, so what entity has weird looking melanocytes like this that have amphiphilic two-toned cytoplasm?
Oh, is this a papilloma?
Yes, good. This is the bapoma, and those are the main features of bapoma. What is a bapoma?
It's like you get loss of BAP1, which is a tumor suppressor gene.
Yeah, BAP1 inactivated melanocytoma. What condition is associated with BAP1 loss?
Mesothelioma, just like other internal malignancies. I think onycho papilloma was just recently cited as another bapoma.
Yeah, they like asking about germline BAP1 mutations and mesotheliomas for whatever reason. But yeah, you can you can stay in this for BAP1. All right. So we're just going to finish off on this, and I will just tell you that, okay, first of all, does anyone know what this is?
Dysplastic nevus.
Okay, good. Now, dysplastic nevus is a controversial entity, as you may know.
Box. I've made a mistake.
Yes, you made the mistake of saying dysplastic nevus on sign out, I bet. And then you got a 10-minute lecture, didn't you?
Yes, I feel it coming.
Yes, exactly. So everyone who's here, don't say it, okay? It's a forbidden word. But you have to know the name anyway. So you got to know the name. You have to know all the name. You're not responsible for knowing, because everyone disagrees on what the name should be. You have to know, you don't have to know what the right answer is. So you'll never get a question on your boards about what is the correct name for this entity? Dysplastic nevus, Clark's nevus, nevus with architectural disorder, atypical. You'll never get that question. Unfortunately, you're still required to know all those names because they can give you this entity and they can give you any one of those names, and you're required to recognize it. So what are the features of the Voldemort forbidden word nevus?
You get bridging, shouldering.
Okay, which one is the major criteria? Bridging or shouldering?
Oh man, I forgot.
It's the shouldering. In fact, you'll get another 10-minute lecture if you mention bridging, by the way. If you mention that with Dr. Neaton sign out. Because it's not that there isn't real bridging that you can see, it's just a lot of people think they look at keratinocyte bridging and they misinterpret it as melanocyte bridging, and he doesn't think that's one of the more important points. But what else can you see? Like, look at this. Look at that. You have a little bit of it here.
Concentric fibrosis.
Yeah, concentric fibrosis or fibrosis. Yeah, so the shouldering, and lentigious monocytic hyperplasia, shouldering, bridging, and concentric lamellofibrosis. You are also not responsible for grading these. You're not responsible for saying if it's mildly dysplastic, moderately dysplastic, or severely dysplastic. Okay. Good job, guys. We'll end it here.
Thank you.
Thanks, Avi.
Great job, Avi.
You're welcome. Thanks all for coming.
Thanks, Avi.